Welcome to Season 4 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Commissioner of Health in Baltimore City. Our goal is to bring scientific evidence and experience to current topics in public health through engaging interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith-Rogers, producer of Public Health on Call. On World AIDS Day today, Stephanie Desmond talks to Johns Hopkins epidemiologist and AIDS expert Chris Beyrer about the status of the global HIV pandemic and how the COVID-19 pandemic has stymied progress in vital programs for HIV testing and prevention here and around the world. Let's listen. Chris Beyrer, thanks so much for joining me.
Wonderful to be with you, Stephanie.
So, World AIDS Day is today, and we have talked a lot about where we've been with the global HIV pandemic. But before we can talk about the future, I'm wondering if you can give us some context on how we got here and where the situation stands today.
Well, it's striking to be thinking about 40 years of HIV and be still in the midst of the HIV pandemic while the world is dealing with COVID. So where we are right now is that we're still just really beginning to understand the impacts that the second pandemic has had on the first. And we've seen, for example, very important impacts on all the aspects of public health in general, but HIV in particular, that you would think of as elective. So, for example, if you're living with HIV and you're on antiviral therapy, there's nothing elective about you being on treatment. That has to continue. And we've seen a great deal of effort and innovation and health systems, programs, and everybody really trying to help people stay on their meds. But what's elective, for example, is getting an HIV test, finding out your status, or embarking on a prevention program like pre-exposure prophylaxis. And that has really been profoundly affected. HIV testing in 2020 just went off a cliff. So we're actually looking, for the most part, when we think about where we are now in the global HIV pandemic, really looking at 2019 data. The 2020 data is just coming in, and it's complex and hard to understand. And of course, we're still in the middle of the COVID pandemic, and it's nowhere near over. But I would say that if you sort of look big picture, we basically had several periods of the pandemic. The emergence and the early years without treatment, which went on for 15 years. Which was an extraordinarily difficult time, basically from 1981 to 1996. And then we had a very painful period where we actually did have therapy, finally, the triple therapy cocktail that worked so well to control HIV and really help people live, but it wasn't available in most of the world. So that's kind of like where we are with the COVID vaccines. These vaccines are safe and they're highly effective. And the total coverage right now in Africa is about 5% of eligible people. So that's where we were from 96 to 2003 or 2004, finally, when there was a global commitment to try and treat everybody living with HIV. That was the period of universal access, with the PEPFAR program, with the UN Global Fund to fight AIDS, TB, and malaria, and really kicking in the billions of dollars that were necessary to do this. So what you have now is that actually the majority, for the first time ever, the majority of people living with HIV worldwide are on therapy. That is a remarkable achievement. That means, of course, that their life expectancy has gone up. So we expect the prevalence of HIV to continue to rise. It's about 37 million people worldwide right now living with the virus, about 1.2 million in the United States. But what we have not really achieved is declines in new infections. So, the US epidemic has been declining at a slow and very insufficient, about 6 to 8% per year declines in new infections. We need that to be way better. if we're ever going to end this pandemic. And globally, we were supposed to get down to fewer than 500,000 infections by 2020. There were over 1.4 million infections in 2020, so we didn't get anywhere near there. And we're not on track to control the global pandemic at this point, remarkably enough, after all this investment. So you really have two different pandemics, one with a long, slow burn, which is HIV, and the other, which is incredibly fast, much less virulent. The majority of untreated people survive COVID. Nobody survives untreated HIV.
So in the United States, I guess it's the story is sort of regional. Is that the case?
Yeah, what has happened over time is that the epidemic has become geographically telescoped down, so more, and used to be bi-coastal distribution. Now it's really the Deep South, and it's a belt of high burden communities, basically going from Texas across the Deep South, Florida, up through the Carolinas, Georgia, Mississippi, Alabama, until you get to Baltimore, unfortunately. And then New York and LA continue to be high burden places just because they had such large epidemics early on. But really, it's now increasingly HIV is an infection of low-income Black and brown people in the South. And it is very specifically concentrated in one population, which is gay and bisexual men who have sex with men, transgender women who have sex with men, and particularly gay people and trans people of color. That's really where the epidemic is most concentrated. So in 2019, which is the last data we have for the US, about 72% of all new infections were in gay men and trans women. And that was disproportionately people of color. The good news is, we have this new tool, this prevention tool, pre-exposure prophylaxis, where you use antivirals to reduce new infections. And we saw in 2019 finally getting to a real level of protection in one population that demonstrates what we could do if we could deal with our inequity problems and our very unjust healthcare system. So in white gay men, we had a 33% decline in new infections, which is just remarkable, between 2018 and 2019. And that is because now 2/3 of white gay men with an indication for PrEP are on PrEP. So we have reached that threshold where we're now seeing it not just as a prevention tool for individuals, but if enough people are on it, you can really reduce transmission in a population. So it is now really a validated public health tool. But what did the decline look like for Latinx men? Almost nothing. For Black men, it's a flat line. And when you look at those two populations and say, okay, so among white gay men with a PrEP indication, we're at 33% reduction. 2/3 of them are on PrEP. When you look at Latino men, it's about 14% are on PrEP. With Black men, it's less than 8%. So what we have is a widening health disparity. And it's really a lot about, the fact that these southern states, most of them Republican-led, have refused to expand the Affordable Care Act through Medicaid. And these are people who have either no or insufficient health insurance and access to health care.
Mm-hmm. This is fascinating. I'm curious about if we turn to Africa.
Yeah,
I'm wondering what's been going on during the COVID pandemic there. I imagine have cracks have appeared in testing and prevention programs.
Yes. Yeah. So the Global Fund has been tracking this. This is the Global Fund to Fight AIDS, TB, and Malaria. And they actually got a substantial additional resources to address COVID in Africa. So they have funding, boots on the ground, and pretty good ability to track what's happening. So they just put out a report on the impact of COVID in Africa on HIV, TB, and malaria. The effects on malaria were pretty modest because, if you get sick with malaria, you are sick. And those people were showing up and getting treated. The impacts on HIV were very similar to what we've seen elsewhere, which is, again, a decline in what you would call elective procedures like getting an HIV test or getting started on prevention. The biggest impact clinically really was in TB and in those people with HIV and TB. And TB is the biggest killer of people living with HIV worldwide. It's a very important opportunistic infection in HIV. And TB testing has declined, TB treatment has declined. There have been a substantial increase in the number of drug-resistant TB cases. So TB has been really hard hit by COVID. And you can imagine why, because it's a respiratory disease mostly, and people are being told not to go, to clinics, and so it's been really challenging. This is not the only area where COVID has had a big impact. Because of the lockdowns, we've seen, for example, now we're having measles outbreaks on the continent because of childhood immunizations. There's been a sharp rise in many countries in the number of unwanted and unplanned pregnancies because of lack of access to contraception. All the sort of basics of public health that are not seen as emergency care and are things that you can put off. Health systems have put off, and we're really paying a price. There've also, of course, been a big increase in a lot of what we would call comorbid or issues in HIV that relate but less directly. So, for example, substance use. Major increases everywhere in the pandemic in substance use, and substance use has always been associated with increasing HIV risk. Depression and mental health, a big risk for people going off their medications. Of course, the pandemic has been a huge mental health challenge. Domestic violence. So, in lockdown, women are often, and men, if they're in an abusive same-sex relationship, and children are now confined with their, abusers. And so we've also seen, which is very unnerving in this country, a big decline in reporting, for example, of abuse, because people are afraid and they're there. And also so much of it is picked up, for example, in schools. That's where kids get seen who are being neglected or abused. When the schools are closed, there's a problem there. And all of those kind of social related factors have long been known to be increases for HIV risk and for people living with virus for going off meds. So that's all a concern as well. And of course, it's not over. We're not out of it. Many countries are having supply chain problems also, as we are, with basic commodities. And as you know, there's been worldwide shortages, for example, of basics of healthcare like oxygen.
So with regards to HIV, obviously we've seen a lot of backsliding during COVID. How do we get out of this? How do we move forward?
Yeah. Well, so I think the most fundamental and basic thing to say is that we have got to address the inequalities in COVID vaccine access. And, Africa has basically now 2/3 of all global HIV infections. Those folks need to be prioritized for immunization against COVID. They're already, some of them will have immunocompromised, particularly the people who are untreated or insufficiently treated. And right now, Africa is not only is it the outlier in HIV, having, the majority of the cases without anywhere near the majority of the world's population, but it's also the least protected against COVID. And, that is right now is not expected to change really very dramatically until 2023 if we stay on the path we're on. And that's just totally unacceptable. I mean, at a human level, at a moral level, but also just a basic public health level. If we can't get immunization rates dramatically higher, we won't be able to control COVID globally, and we're going to be at risk for variants emerging. So it really is incredibly important. Fortunately, the U.S., through the PEPFAR program, has built an extraordinary HIV infrastructure in many of these countries in Africa. And so I have been arguing and publishing and pressing the administration to use that platform for COVID, and to do so very quickly and aggressively. So I just did a talk at the Center for Strategic and International Studies in Washington, and we had a presentation on the COVID vaccine rates in the PEPFAR-focused countries, and it's just abysmal. It's just abysmally low. So that effort has not really started. And just to give you a feel, the only PEPFAR focused country outside of sub-Saharan Africa in our region is Haiti. And Haiti, of course, is the highest burden country in the New World, in the Western Hemisphere, for HIV. And the COVID vaccine coverage in Haiti is under 1%. Under 1%. I mean, that is just, it's a kind of inhuman. Now, granted, they are in a political chaotic situation right now, and the country is in a very fragile position. But even before the killing of the president, they still, really hadn't started immunization. We have spent a great deal of the taxpayers' money establishing a system to deliver antiviral therapy to people living with HIV in Haiti. And in my view, it's absolutely unconscionable not to use that platform to deliver COVID immunization, treatment, and care. And that's how we're going to get out of this. We're going to get out of this through global solidarity. And we're going to get out of it through being way more proactive about ramping up manufacture and distribution. And we have to press the companies harder. Moderna has basically reneged on its commitments to do global distribution. This is their first product they've ever brought to licensure. A lot of the taxpayers' money went into helping them develop it. Now they're trying to cut the NIH scientists who worked on the vaccine with them out of the patents, you may have seen. And they are not delivering for the developing world at all. Well, we have some pressure there, and we should be using it. And we can't use a charity model. This is not an issue of charity or goodwill. This is an issue of ramping up manufacture and distribution to immunize the whole of humanity, and before the end of 2023 or 2024.
Right. And so I guess what you're saying is once we get the COVID pandemic under control, then we can go back to focusing more on the HIV.
Well, we can do both. The fact of the matter is that I'm not saying that we shouldn't be also using the HIV platform for HIV. It's that, what we've been doing is asking those people, the same people, by the way, to just work harder and without, increasing the funding. It's been flat funded. That's unacceptable. It really needs a significant increase in resources.
Chris Beirer, thank you so much for joining me.
Thank you, Stephanie.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, and Matthew Martin with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holes Fernandez and Caroline Wong. Thank you for listening.